Boa noite, pessoal. A quem está nos ouvindo de longe, mais uma reunião do Serviço de Oncologia do Aparelho Digestivo da Beneficência Portuguesa de São Paulo. Reunião esta transmitida do Hospital BP Mirante. Meu nome é Bruno Gilberstein e eu participo de um grande time organizado por esta instituição e tenho a honra e o prazer de trazer de longe, de muito longe, uma das figuras emblemáticas da cirurgia oncológica e da cirurgia do trato digestivo alto, que é o professor Jimmy So de Singapura. Os horários são muito inconvenientes. Nós passamos essa reunião para as 8 da noite, porque em Singapura são 7 da manhã. E ele está conosco desde as 6 da manhã de Singapura. Eu vou apresentá-lo. Ele é o chefe da divisão de cirurgia oncológica do National University Cancer Institute of Singapore. É diretor e consultor da divisão de cirurgia geral do trato digestivo alto, do Upper GI, e é professor de cirurgia da Yonglun Escola de Medicina da Universidade Nacional de Singapura. Eu diria que ele é um dos maiores cirurgiões oncológicos do trato digestivo alto da atualidade, e a experiência que ele tem com câncer gástrico, poucas pessoas no mundo têm. E, gentilmente, ele aceitou apresentar essa palestra, que é um marco no tratamento do câncer gástrico, como vocês verão. My dear friend Jimmy, nice to have you among us. Thank you for accepting this inconvenient invitation at that time of the morning in your country. I have to thank you in the name of our hospital, Beneficência Portuguesa, and our group of oncology on digestive tract. And I just made the presentation of a great world surgeon with the most important experience in gastric cancer. Jimmy, please be so kind and make your presentation. Thank you again very, very much for being with us. I can hear you. I cannot hear you, Jimmy. No. It's mute. Not yet. Bem, vamos aproveitar enquanto o professor Jimmy So está arrumando para variar. São apenas uns 20 mil quilômetros de distância entre nós. E a transmissão é ao vivo. Então, antecipando a palestra do professor Jimmy, eu tive o prazer de assisti-lo num webinar organizado pela Universidade de Singapura recentemente. E fiquei, de fato, assim, impactado com o que ele trouxe em termos de novidades e de perspectivas para o tratamento do câncer gástrico avançado. Então, nós que lidamos aqui em nosso meio com 80% de cânceres avançados, teríamos que, pelo menos, ter acesso a essas perspectivas que se desenrolam e desenvolvem para o tratamento do câncer gástrico. Eu acho que nós vamos poder aproveitar bastante, e como o contato do professor Jimmy e ele é de fácil acesso, nós poderemos, no futuro, contactá-lo quantas vezes mais houver necessidade por aqueles que se interessarem pelo tema. Aproveitando, eu queria falar que o câncer gástrico tem uma incidência mundial de 1 milhão de casos por ano. E a mortalidade mundial também é de 1 milhão de casos por ano. No Brasil, nós estamos com 20 mil casos por ano. E também temos uma mortalidade de 20 mil casos por ano. E, mesmo assim, quando o câncer gástrico é ressecável, nós temos uma sobrevida de 10 anos que chega a 60%. Então, todo o investimento que pudermos fazer para tratar essa afecção é válido, e nós, médicos, oncologistas e cirurgiões, temos que fazê-lo. Jimmy, you hear me? But I don't hear you. You can close your presentation and also your video, close everything, and just begin again. Close your computer, close your presentation, close your transmission. End your transmission, and then come back.
Hello?
Yes, Jimmy, now we are together.
Can you hear me?
Yes, perfectly. Fantastic. Great.
Okay, let me turn on my, give me a second.
Presentation.
Sorry
Yes.
about that, yeah.
No problem. We thank you very much for your kindness.
This is technologies. Sometimes technologies has some problems.
We are just 10,000 miles far away, so...
It's quite nearby, quite nearby. Give me a second. Yeah, and I can't find the PowerPoint. Yeah, I can't find the PowerPoint. No, it's still... We can't find the PowerPoint.
Pouco nós estávamos comentando, né, da perfeição da internet asiático, né? E só para a gente não ficar assim muito humilhados, lá também tem problemas.
Okay.
Okay, Jimmy.
Is it okay? Yes, thank you.
Fantastic,
Thank you.
fantastic.
I'm so sorry for the delay. Yeah. Good evening, ladies and gentlemen. Thank you so much. I'm very happy to be here, and thank you so much for Professor Bruno Sippenstein for the kind invitations. I was here in São Paulo in 2015, and this is a beautiful conference organized by Professor Bruno Sippenstein for the 11th IGCC. Then thanks for the kind invitations for Professor Bruno. And apart from the Congress, I of course, I visit this spectacular, beautiful Iguazu Fall. And I have a great memory of Brazil. Just going back to the where I come from, I'm from Singapore. As Professor Bruno Sippenstein mentioned, that there's only 40 hours flight from between São Paulo and Singapore. So Singapore is actually a very small city. It's a city-state with a population of 5 million people. And we are a multi-ethnic society. This is a place I work, which is the National University Health System. It's a university hospital together with the Faculty of Medicine of the National University of Singapore and also the National University Cancer Institute. And this is our group. It's Upper GI Multidisciplinary Tumor Board. We have started this group in 2004, close to 20 years ago, which is a group made up of surgeons, oncologists, radiologists, and pathologists, truly a multidisciplinary group. And many of the work is later on speak on is actually the idea from our multidisciplinary group. In terms of research, I belong to this Singapore Gastric Cancer Consortium. This is actually a research consortium, a national effort comprised of clinicians from hospitals, universities, and the research institute, both the scientists, the engineer, and the clinicians. And our goal of our gastric cancer consortium is to redefine the management of gastric cancer to benefit our patients. We are very thankful. We received a strong support from our National Medical Research Council, and we received the first flagship grant in 2007. Subsequently, we have successfully got 2 renewals, received a total research grant of $60 million. And we are very thankful for this support from research funding. Therefore, talking about the outline of today's talk, and I know that the audience will be, most of them are oncologists or surgeons. Therefore, I hope that in the next 30 minutes, I just will share our experience on the role of surgery for advanced gastric cancer with the following features, including liver metastasis or para-aortic nodal metastasis. Last but not least, on advanced gastric cancer with peritoneal metastasis. Just a background of this topic of metastatic gastric cancer. No doubt at the moment, palliative chemotherapy, unfortunately, is still the current standard of care. But we notice that there's outcomes are generally improving with a better survival of our patient due to the advance of chemotherapy. And recently, the survival for metastatic colon cancers with chemotherapy and subsequent conversion surgery have improved significantly. And this gives some insight for us as a gastric cancer clinicians to manage this problem. First of all, this is a study called REGARDER study. It's an international multi-center randomized control trial, randomized a gastric cancer patient with a gastric cancer with either liver, peritoneal, or para-aortic lymph node metastasis into either standard arm of palliative chemotherapy, or the investigation arm is upfront gastrectomy followed by a chemotherapy. As you can see, that this is the final primary endpoint, the overall survival. There's no difference between the two groups. Hence, that there's no advantage of gastrectomy for this group of patients. Then our study has shown that there's no role for upfront gastrectomy in metastatic gastric cancer. This is the latest Japanese gastric cancer treatment guideline, just published early this year. As you can see that for any new cases of gastric cancer, we divided whether they have metastasis or without metastasis. For without metastasis, if a very stage 1 disease, we will try endoscopic treatment or surgery alone. For stage 2 or 3 disease, the treatment will be a curative gastrectomy together with adjuvant chemotherapy. However, for patients with metastasis, M1 disease, for most of the M1 disease, that the treatment will be chemotherapy, radiotherapy, palliative treatment. But there's a 3 subset of group. Those patients with 16A1, A2B1 lymph node, these are para-aortic lymph node metastasis, or patients with resectable liver metastasis, or people with early peritoneal metastasis. This group of patients, the treatment are still controversial, and it is evolving, the treatment. And this is the topic of discussion today. This is our current management for our patient with metastatic gastric cancer. We think that there's there's 2 subtypes of metastatic gastric cancer. One group is called incurable disease. This group of disease are patients with a metastasis either in the distant organs such as the bone, the spine, the lung, or the brain, or a patient with a multiple sites of metastasis, for example, liver together with para-aortic lymph node metastasis, or liver with bone metastasis. This group of disease, we declare the disease, unfortunately, are incurable, and the standard treatment will be upfront, will be systemic palliative chemotherapy, plus or minus target therapy, such as trastuzumab, if the disease are HER2 positive. But we also believe there's a group of metastatic disease called potential curable disease. This is a group of patients with liver metastasis alone, or people with only para-aortic lymph node metastasis, such as the station 16A2B1, or people with early peritoneal metastasis alone. And we believe this group of patients, yes, that the systemic chemotherapy is still the first line of management. But however, if the patient have a very good response, which indicating that this is the tumor have a good biology, we will consider the patient for conversion surgery if the patient have a very good response, and discuss it together with our team in the multidisciplinary tumor board meeting. We'll first talk about evidence for the treatment for gastric cancer with liver metastasis alone. This is a large meta-analysis just published in Annals of Surgery, looking at the result of a surgical resection for liver metastasis from gastric cancer. Though this is the result on the overall survival. As you can see from this meta-analysis of multiple studies, you look at the forest plot, the graph showed that there's significant improvement of survival for the group of patients with surgical resections. In terms of overall survival, if hazard ratio of 0.5, 95% of confidence interval of 0.4 to 0.6, highly statistically significant. This is the largest series on the long-term outcome for surgical resection for gastric cancer liver metastasis from our friends from Japan, looking at patients with a total number of 256 patients with gastric cancer of liver metastasis. About 1/3 of them have synchronous liver metastasis, and another 2/3 of them have metagenous liver metastasis. And mean number of liver tumor resected is about 2. Maximum size of the liver metastasis is 3 centimeters. A small proportion of the patient receive some form of chemotherapy either before or after the liver resection. This is the finding of the paper. This is the overall survival of this 250 patients underwent liver resection for gastric cancer liver metastasis. They have a 5-year survival of 30%, which is in this selected cohort of patients, which is very promising. And in addition, the paper also identified a selection criteria for liver metastasis. These are there's 3 good prognostic factors. The one including less equals 3 or less liver metastasis. The largest liver lesion should be 5 or less than 5 centimeters, and the primary tumor should be T3 or below without serosal invasion. And so you can see from the survival curve, if there's none of these factors, the survival are far better than if there's presence of 1 or 2 of these factors. Therefore, a short summary of gastric cancer with liver metastasis. Though clinical resectable gastric cancer with liver metastasis are uncommon, but for very selective patients, long-term survival is still possible follow out-zero resection. And hence, prospective study is warranted to confirm these findings. Next topic are patients with gastric cancer with para-aortic lymph nodes or station 16 lymph nodes. These are the patients with advanced gastric cancer have a lymph node around the abdominal aorta, in between the aorta and the IVC. Para-aortic lymph node metastases are considered M1 disease in all our guidelines. And I think from one of the important studies from Professor Sasako in Japan, studied that prophylactic para-aortic lymph node dissection is unnecessary. And but however, study also find that both from Europe and also from Japan show that therapeutic para-aortic lymph node dissection may have cure up to 20% of the patient with these metastases. This is a prospective phase 2 multi-center study from the JCOG, the Japan Clinical Oncology Group, one of the well-known cancer groups in gastric cancer, looking at neoadjuvant chemotherapy followed by D2 gastrectomy and para-aortic lymph node dissection for gastric cancer with extensive lymph node metastasis. These are the patients with either para-aortic lymph node or very bulky celiac axis lymph node with lymph node more than 3 centimeters in diameters. These are bulky lymph node or para-aortic lymph node metastasis. And the patient receives preoperative chemotherapy followed by D2 plus para-aortic lymph node dissection, PEN. This is the result. The overall clinical response rate is 65%, and the overall survival for this group of patients is 53%. In addition, on subgroup analysis, they find that some patients have either with a bulky N2 lymph node or para-aortic lymph node alone have a better survival compared to people who have both para-aortic lymph node and bulky celiac axis lymph node. Hence, the study suggested preoperative chemotherapy followed by para-aortic lymph node dissection and D2 gastrectomy was safe and effective. And a randomized control trial, however, is needed to confirm the role of this strategy. Next topic I will spend a bit more time on is the topic that we are very interested on is the patient with peritoneal carcinomatosis. Peritoneum is the most common site of metastasis, both from primary cancer, gastric cancer or from recurrent gastric cancer. Importantly, the symptoms of patients with peritoneal metastasis are very distressing and it's very difficult to treat medically, such as malignant ascites or intestinal obstruction. We all know that the prognosis of these patients are very poor with standard conventional systemic chemotherapy. However, there's a variety of treatment options nowadays for peritoneal carcinomatosis, including systemic chemotherapy, which is still the current standard treatment. We also have HIPAC, which is the hyperthermic intraperitoneal chemotherapy, usually together with cytoreductive surgery. We also have a catheter-based intraperitoneal chemotherapy. And last but not least, which is the more newer technique called pressurized intraperitoneal aerosol chemotherapy, or PIPAC. I think many of you know about HIPAC, hyperthermic intraperitoneal chemotherapy, and cytoreductive surgery. Usually, this is a very major surgery, but with usually aim for cure. This treatment is usually only allowed once, a single major surgery, and the treatment is a very invasive treatment, including multi-organ resection and peritonealectomy. However, we also know that the result of HIPAC depend on the cancer type and also the disease burdens. And due to the more aggressive nature of gastric cancer, the result of HIPAC are less effective for gastric cancer. This is a large series from one of the center from France, Lyon, look at the result of HIPAC on the survival. As you can see that HIPAC is very effective for tumors such as pseudomyxoma or appendicular tumor, but there's worse for people with gastric cancer primary. Next treatment for gastric cancer with peritoneal metastasis, catheter-based intraperitoneal chemotherapy. This is a concept is like peritoneal dialysis. It says the patient will insert the enduring catheter with a subcutaneous port like this, and will insert this catheter into the peritoneal cavity laparoscopically, and the patient will receive chemotherapy by the nurses in the chemotherapy center. The advantage of this catheter-based IP chemotherapy is a simple outpatient treatment. In addition, the patient can receive repeated dosing, which is very important for patients with more systemic disease, advanced disease. This cartoon shows the concept of intraperitoneal chemotherapy. This is the tumor on the peritoneal surface, comparing if intraperitoneal chemotherapy versus intravenous drug chemotherapy. Certainly, when you give the chemotherapy intraperitoneally, the chemotherapy you give a higher drug exposure to the tumor on the peritoneum, and also less systemic side effect. In addition, the bioavailability of the chemotherapy can also moderated by both the physical property and the biological property of the agent and the peritoneum and the environment. We have studied this regime, this treatment strategy for quite a number of years. This is our regime, and we give a combination of a systemic treatment, including capecitabine and oxaliplatin. This is a very standard, common chemotherapy for patients with advanced gastric cancer. But on top, the patient will give intraperitoneal paclitaxel in a 3-weekly cycle. And this is our result. We have previously published we published 2 papers on this. This is the final result we just analyzed. As you can see that comparing to the historical control, which is the green color, the patient received only systemic chemotherapy alone with gastric cancer peritoneal metastasis. The patient who received IP intraperitoneal chemotherapy have significantly better survival. The median survival increased from 10.6 months to 14.6 months. And the 1-year survival increased from 28% to 66%. And this is statistically significant. For certain group of patients, we managed to convert them to undergo a conversion gastrectomy. the indication for conversion surgery are the patients who we have excellent response after the IP chemotherapy. The peritoneal fluid cytology become negative. There's no extra peritoneal metastasis, and also no gross peritoneal metastasis on laparoscopy. Therefore, in this group of patients that we'll discuss in the tumor board, and the patient's conditions are fit, and the patient will be advised to go for D2 gastrectomy, but without peritoneectomy, just a gastrectomy, D2 gastrectomy. And this is our survival. And the patient who received conversion surgery have much better survival compared to the group of patients with IV or just chemotherapy alone. And the median survival for a group of patients who underwent conversion surgery follow chemotherapy is 2 years, with 1 year survival of 85%. This is, I think, is very encouraging for patients with peritoneal metastasis from gastric cancer. Just one quite a recent example. This is a 70-year-old man with a patient with underwent IP chemotherapy because of peritoneal carcinomatosis from gastric cancer. We have mean PCI of 23, and with presence of malignant ascites. You can see that they have peritoneal nodules both in the supracholic and infracholic compartment. And this is the after X cycle of the chemotherapy. This is how it look on laparoscopy. You can see that the peritoneal nodule you saw before in the abdominal cavity have disappeared. There's no more visible peritoneal nodule or seen. And this is the catheter we saw. The only nodule we saw this on the center of the screen was actually turned out to be a negative on a frozen section. So this patient underwent total conversion, total gastrectomy, and the histology is a differentiated carcinoma with nearly complete pathological response. All the peritoneal nodule, the fluid cytology and resection margin are negative for malignancy, and the patient still survive. Of course, now we have already have phase 3 randomized control data on IP chemotherapy. This is a clinical trial called Phoenix trial from Japan, which is a randomized control trial comparing systemic chemotherapy with S1 and cisplatin versus systemic chemotherapy plus intraperitoneal paclitaxel. Therefore, this is the overall survival, which is a primary endpoint. The blue line are the one who receive IP chemotherapy. The yellow line are the one who receive systemic chemotherapy. Unfortunately, although there's some survival benefit for IP chemotherapy, but p-value is 0.08. The median survival is 15 months for systemic chemotherapy and 18 months for the IP chemotherapy. However, if you follow up the patient longer, you can see that the survival curve for the two group of patients diverge. And you can see that here, the 3-year overall survival for the systemic chemotherapy is 6% as expected, but the people with IP chemotherapy is 22 months, nearly 4 times of the improvement. So indicating that these regimes really have a very promising result. The next treatment available nowadays is called PIPAC, which is called a pressurized intraperitoneal aerosol chemotherapy. This treatment is pioneered by Professor Raymond from Germany, and what it does is as shown in this cartoon, and we convert the liquid chemotherapy solution into aerosol through a high pressure injector and a micro pump. And this chemotherapy will turn into aerosol, and this the aerosol will be injected under pressure into the peritoneal cavity. And because this is a gas form of chemotherapy, they will distribute and circulate within the peritoneal cavity. The whole procedure is under laparoscopy. And at the end of the procedure, the residual aerosol chemotherapy will be disposed through a closed waste system. Just to show you a principle of this technique of pipette. And this is the nebulizer called Capnopan. Is the device to convert the chemotherapy solution into chemotherapy aerosol. Therefore, we do this procedure done in the operating room. The patient will undergo a routine laparoscopic examinations, and the pipette is under laparoscopy. Therefore, the machine on the left here is the high pressure injector, which is commonly used for contrast injection in the CT scan room in our radiology suite. And this is the nebulizers, which put into the 10 millimeters choker. Another choker is for the camera, the 5 millimeter camera. Then once we finish the laparoscopy, then we'll connect it to the nebulizer, and we activate it, then we apply the intra-abdominal chemotherapy aerosols, like this. Then the procedure takes about 30 minutes, and this chemotherapy aerosol will circulate within the abdominal cavity to go to the peritoneum. During the procedure, because of the occupation safety, nobody will be in the operating room, and the procedure is performed administered remotely. There's some preclinical data to study the mechanism of pipette. This is comparing a blue dimethylene blue applied through pipette versus a conventional liquid lavage. You can see the distribution and the dye. When you apply through aerosol or gas, then you can see the blue dye are more intense, both in the intensity and also the distributions are more homogeneously compared to the conventional liquid lavage. And this is an in vitro model. Look at the depth of penetration of the drugs applied through a pipette compared to a lavage. As you can see that when you apply a pipette with staining, fluorescent staining of the chemotherapy agents, those agents can penetrate deeper into the peritoneum, up to 7 cell layer, compared to just on the surface for the conventional liquid lavage. This is a potential advantage of pipette versus standard chemotherapy. This is the chemotherapy are better distributed because it's a gaseous form and can distribute more homogeneously within a closed environment like a peritoneal cavity. The chemotherapy agents, the gas was applied with pressure, therefore the drugs will be penetrate deeper into the tumor tissue. There's a minimal toxicity because the systemic absorption of the drugs are low. And last but not least, pipette is done under laparoscopy and is minimal invasive. And because of laparoscopy, you can allow repeated applications. And then you can also, through the laparoscope, you can assess whether the peritoneal disease or the tumor are responding to your treatment, which is sometimes very difficult to measure by the conventional CT scan for peritoneal diseases. Certainly, pipette the interest of pipette is going fast but healthy. This is a graph show the number of procedure, publication, and clinical trial since the start of in the beginning of 2012 when the first report of pipette started. And then at 2017, there's this report from British Journal of Surgery. And after that, in the last 2-3 years, you can see that the more and more reports are describing the use of the pipette worldwide. This is our operative techniques. This is a video on the operating room. The procedure is done under general anesthesia. The administration of chemotherapy is done outside the room for occupation safety. both. And this is the view from the laparoscope. Once is activate the pipette system, and the aerosol, you can see that will be injected into the peritoneal cavity, and this typical slow storm phenomenon when we applying pipette. The procedure will take up 30 minutes with a pressure of the gas of 200 psi. This is a recent review from Lancet on the rationale, evidence, and indication for pipette, which summarized about 1,800 pipette in 800 over patients worldwide. And you show that in this report, show that pipette is safe, feasible in over 80% of the patients. And importantly, this procedure is very safe because complications are rare, and 3% for prospective studies, ranging from 0 to 11%. And most of the event, more than grade 2, is very minor. Overall mortality is 2%. Most of them are due to the advanced cancer, not related to the pipette. But also importantly, pipette is minimal invasive. The patient have a very minimal impact to the quality of life, which is very important for a patient with advanced cancer. This is our own experience in our own hospital. Our early experience is have 41 pipette procedure for different GI cancer, mainly for gastric or colorectal primary, with a median age of 60 and PCI score of 15. Mean operative time is about 1.5 hours. And we have low mortality, and 2 cases of, but 2 patients have experienced some mild pancreatitis after the procedure. These tables look at the cohort of gastric cancer with a pipette, study the oncological efficacy. And these are the 4 reported series in the world so far, a small series. In average, about the response is ranging from 50 to 79%, with a median survival about a year. But bear in mind that most patients on this series are heavily treated with multiple lines of chemotherapy. These are the tables, put up some of the selected prospective series of pipette worldwide. As you can see that many of the studies are in Europe, and there's in France, there's already started a phase 3 randomized studies, look at the pipette for ovarian cancer primary. In the United States, Mayo Clinic and City of Hope have started a phase 2 study on pipette. And in Singapore, we have also have done 2 studies on pipette. And this map show that how's the pipette worldwide. You see that most pipettes are used in Europe, but now it's also spread to both the Asia Pacific, Australia, and Americas. How about HIPET versus pipette? In HIPET, usually we know that it's curative intent, but the procedure is maximally invasive for very highly selected patients. But HIPET is limited by limit drug penetration and distribution, only allow one single treatment. We can't have repeated treatment, and the patient, because of the major surgery, have significantly loss of quality of life. Compared to pipette, at the moment, pipette is still palliative intent, but this procedure is really minimally invasive. Therefore, it's applicable for most patients with peritoneal metastasis. But the advantage of pipette is because it's gas, therefore it can allow better drug distribution and drug penetration. The procedure can do repeatedly, and the patient can maintain their quality of life, which is important. So in summary, ladies and gentlemen, with improvement of chemotherapy, role of surgery for metastatic gastric cancer is rapidly evolving. Intraperitoneal chemotherapy have promising results for patients with peritoneal metastasis, especially those who can undergo conversion surgery after good response with a chemotherapy. Pipette is a low-vol treatment for peritoneal metastasis, and many clinical trials are ongoing worldwide. But certainly a multidisciplinary management is essential to optimal outcome for our gastric cancer patients. Just want to acknowledge our group, which called Singapore Peritoneal Oncology Group or sports group. And of course, we want to thank our patient and family for the support for our research. With this, thank you so much for your attentions, and I'm happy to take any questions or comments. Thank you.
Thank you very much, Jimmy, for this outstanding presentation. We are everybody is amazed with your presentation. I had the opportunity to see it in the last webinar, and I was deeply impressed. I am taking just some minutes because there is a delay on the YouTube presentation. We have people all over the country, from the north part to the south part of the country. Everybody is listening, and I have some questions for you. I'm just waiting 2 minutes to finish your presentation by YouTube. I'm making a review of your presentation because I'm seeing it. Well, you know, there is a lot of intention to go to treat those patients. And in Brazil, we have almost 80% of these patients are of advanced gastric cancer. So for us, it's a good choice and opportunity to have those kind of treatments. We perform PIPAC. We did not for gastric cancer, but for other tumors. And now we are going through a prospective study on intraperitoneal chemotherapy. So my first question would be, what about comparing PIPAC, HIPAC, and intraperitoneal? How we have to choose the patient, how we get on and say, well, I'm going to do this or that, and then try to convert.
In terms of, thanks, yeah, in terms of history, with research, I think HIPAC have the longest history. And but we also know that HIPAC is only very depend on the tumor specific. If people with ovarian or pseudomyxoma, HIPAC certainly have a role. And in fact, there's a phase 3 study to support that. But not for gastric cancer. Gastric cancer are usually more aggressive. Therefore, HIPAC, this treatment is not, the results show that HIPAC is not suitable for gastric cancer, for most of the gastric cancer. And in terms of IP chemotherapy, I think the work from Professor Ishigami from Tokyo University are very, very impressive. And because of those his work and his results, his publications, we adopted this since about 10 years ago. And the right now, IP chemotherapy is our first line treatment for our patient with gastric cancer with peritoneal metastasis. And because of the phase 3 data and the phase 2 result from multiple groups. Therefore, we believe that still, in terms of scientific evidence, IP chemotherapy have more scientific evidence, and the results are very promising. Therefore, our first line of management now using IP Celox plus IP paclitaxel. And PIPAC, on the other hand, is a very interesting idea, and it's minimally invasive and a very different pharmacokinetic because it's gas and with pressure. And we hope that this is maybe more effective, but it's still a new procedure. Therefore, you can see that now more and more study coming up, but I think it will take a few more years to have a more solid, strong evidence. So right now, I think many groups, I think from us, from Europe, from Europe, from Australia, are looking very enthusiastically on pipette. But in terms of scientific evidence, we still think that IP chemotherapy have more data to support, and our own result also support the use of IP chemotherapy.
Thank you. Yes, it's our opinion too, and we are going through the IP. But as a new therapy, I'd like to know, because we have no experience with that on gastric cancer with PIPAC. But after PIPAC, if you have a good response, would you perform a gastrectomy, or you maintain the patient on chemo?
No. Therefore, right now ours is still on the clinical trial, and it's a phase 1 trial. Therefore, many of our patients have heavily treated with multi-low line of chemotherapy, and therefore we don't have a case we can convert to gastrectomy yet. But the group from France in the Lyon, they have reported people with pipette and as good response, and followed by a conversion gastrectomy. And the results are quite promising. Therefore, I think if the patient have a good response with a pipette and many of time together with systemic chemotherapy, then I think there's no reason, if they really all the peritoneal metastases have disappear, then I think there's a role to have undergo a conversion surgery to remove the primary tumor, just like the IP chemotherapy.
Thank you. There is a question here. It's about a real case, a 58 years old patient with plastic linitis with signet ring adenocarcinoma. Laparoscopy, just one nodule. And he was submitted to 8 cycles of FLOT. Then new endoscopy showed, endoscopy and laparoscopy showed CT negative for tumor. What would you do? Continue with, make a HIPAC or only resection? Would you resect it, or would you do a HIPAC?
Thanks. This is interesting. I think we also have some experience on this. People with very, very good response with perioperative chemotherapy such as FLOT. And this patient actually unfortunately have already peritoneal metastasis. It's a stage 4 disease. And we'll discuss with the patient, if the patient, because they have a good response, if the patient have a good fitness, we will suggest the option of patient have a conversion gastrectomy. We won't perform a peritonealectomy, but we'll just perform a primary tumor resection, and with the goal to remove the primary tumor alone. And this is the theory is to remove the primary site, where many of time they will have microscopic disease remaining. And by removing that, they reduce the chance of mutation. But after that, we'll continue the patient with a chemotherapy because this patient have a systemic disease. Therefore, we'll discuss the case in the MDT. If the patients are fit and good response, we may put forward for conversion gastrectomy.
Another question. There is still a role for palliative gastrectomy? There is still place for palliative gastrectomy?
I mean, if it's for symptoms, for example, if it's obstructions, perforations, or bleeding, which is all the other treatments are not available or unsuccessful, then this is more for symptom control. It's not common nowadays. And but palliative gastrectomy after a chemotherapy, just like a conversion gastrectomy. These are people with a chemotherapy first, but good response. Yeah, then we may perform a gastrectomy. It's still called palliative gastrectomy. I mean, it's still a stage 4 cancer, but most of our oncology believe that this may have some survival benefit.
Okay, Jimmy. I think that those were the main questions, and you did a fantastic presentation. I have to thank you very, very much for your kindness to be with us at that time in the morning at your place. And I'm sure that we will be very happy and honored to have you back in the next future. I want to deeply thank you again for your outstanding presentation, and let my invitation for future meetings. Thank you.
Thank you. Thank you so much.
To everybody here in Brazil, and good morning for you, and a nice day for you there in Singapore. Thank you very much, Jimmy.
Thank you, Professor Silberstein, and all our friends and colleagues from Brazil. Please take care and stay healthy, and hope to see each other physically soon.
Thank you very much.
Thank you.
Have a nice day.
Take care.
Thank you.
Thank you. Same to you. Take care. Thank you so much.
Muito bom, pessoal.
You are the only participant in the conference.